There we go. So we're going to move right into our first keynote presentation of the day. And I'm going to welcome Dr. Brandy Winquest, who will be the moderator for this event. Dr. Winquest is the Executive Director, Academics and Learning in the Saskatchewan Health Authority. As a member of the Saskatchewan Health Authority's senior leadership team, she provides oversight for research, ethics, and academic health science departments. Her research interests span the areas of perinatal epidemiology, health services, and population health. On that, I will turn it over to Dr. Winquest to moderate this exciting keynote this morning.
Dr. Winquist, it just looks like we've got you muted. If you'd like to unmute.
There. Okay, welcome everyone and good morning. It's my pleasure to introduce our keynote speaker today. Dr. Gary Groot is a professor, surgical oncologist, and clinician scientist at the University of Saskatchewan. He's also the Director of Medical Quality Improvement within the SHA. During the pandemic, he has been leading a team to rapidly synthesize evidence for decision making. One of these reports looked at the topic of long COVID. And this morning, Dr. Groot will share with us the current state of evidence on this topic and also what can be done to address this unmet need in our province. So with that, I will hand it over to you, Gary.
Thank you. Let me see if I can share my screen. Excellent. Thank you to Dr. Winquest for that introduction, and to the organizing committee for inviting me to talk to you today, this morning, about the post-COVID condition. My learning objectives for today are to understand the current evidence around the post-COVID condition, to consider possible options for addressing the post-COVID condition here in Saskatchewan, and to explore to some extent the research needs associated with that. I don't have any disclosures related to this particular topic. Most people know me in Saskatchewan in my role as a general surgical oncologist working here in Saskatoon. But quietly in the background, I've been building a health services research program in community health and epidemiology at the U of S that's aligned with the position that I currently hold in the SHA as the Medical Director for Clinical Quality Improvement. I began my academic appointment in 2015, and I was just nicely reaching my stride in developing that program when the pandemic hit, and the world as we knew it turned upside down, not just for me, but for everyone. At the very beginning of the pandemic, I offered to provide support to Dr. Mike Kelly and my SHA co-lead in clinical excellence, Colin Hartness, as they scrambled to construct a COVID pathway for patients to follow in Saskatchewan. It didn't take long before the Emergency Operations Committee, or EOC, contacted me and asked if we could provide similar support to them. And with the approval of Dr. Susan Shaw and Dean Preston Smith, we quickly brought together an interdisciplinary, cross-jurisdictional evidence support team that became dubbed the think tank. Trust me, that wasn't my idea. I think that was John Froese. Key to this working well was a unique collaboration that occurred between the College of Medicine, the SHA, and various portfolios within the SHA, actually, academics and learning and clinical excellence, the university, librarians at the university, and Health Quality Council. And these groups all came together with a unified focus to support the pandemic response. We formed teams of that involved clinical experts in their field and supported those clinical experts in aligning them with librarians, master's and PhD trained researchers, and developed a standard process for doing these rapid reviews of gray and published literature. In order to stay focused on the important issues that were facing the EOC and not get overwhelmed with what a colleague of mine or a mentor of mine referred to as recreational questions. I met regularly with the EOC leadership and sat on EOC meetings to try and anticipate what their needs would be and try and address the questions that were most pressing. One of the over 100 reviews that we did was a review on long COVID, as it was known at the time that we did that review in mid-March. And we've updated that for this presentation. That work led to a request from the EOC for myself and Dr. Gary Lanasse in rehab medicine to establish a working group to explore the implications of long COVID for our province. So we in turn brought together a team of patient advisors, educators, primary care physicians, public health professionals, researchers that want to do this work. And we came together and we created an evidence-based report that was presented to the EOC in mid-August. This presentation this morning is largely based on the work that went into that report to the EOC, as well as several conferences that I attended prior to and subsequent to that report, including a Best Brains event hosted by CIHR and the Public Health Agency of Canada, World Health Organization meetings. There was one back in February, if I recall correctly, and one more recently, and a Can COVID event. When we set about trying to do this report, we quickly realized that there was a lot of moving parts. And so we broke things into 4 buckets of work. One was the epidemiology and modeling to try and understand the scope of the problem. Another was around educational needs that would be required. A third was around the models of care that we could recommend. And finally, the research needs. What exactly is post-COVID condition? Recently, this was when we were working on our report, that was one of the challenges, that there wasn't a clear definition of post-COVID or long COVID as we understood it. But just recently, the World Health Organization proposed using this definition, and calling this condition the post-COVID condition, so that there would be unity amongst researchers across the world. And I'm just going to read this out because I think it's a very well done definition that was arrived at through a fairly in-depth Delphi approach. They describe post-COVID condition as occurring in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last at least 2 months and cannot be explained by an alternative diagnosis. Those are all important components of the definition. Somebody's not muted. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, and then there are others, and I'm going to go into some of the others in a bit, which generally have an impact on everyday functioning. That's an important part of the definition. Symptoms may be new onset, following an initial recovery from an acute COVID-19 episode, or persistent from the initial illness. And symptoms may fluctuate or relapse over time. And there will likely be a separate definition that applies for children. While the researcher in me really appreciates the World Health Organization definition, the physician in me finds these words shared by a patient in this part of our report that has post-COVID condition to be much more poignant. And I'm going to read this. I hope you don't mind. This patient shared this with us as a team, and I read, "I continue to experience muscle aches, fatigue, my heart races, breathing increases with minimal exertion. On 2 occasions, I watched as bruises appeared on my hands. Tinnitus has increased. Taste and smell is minimal. I have only recently been able to faintly smell bleach. I've noticed changes with my digestive system. I believe my communication and cognitive skills are diminished. Memory and retention is a challenge, which has impacted my efficiency at work. My poor motivation and fatigue has made me question whether I am depressed. Simple tasks of emptying the dishwasher or washing my hair seem like a chore. I push through, but feeling this way is foreign to me. I wonder how hard to push myself, or am I still in recovery and I need more rest? Throughout my life, I have always had low blood sugar, Recent blood tests show high blood sugar. My blood pressure is higher. My thyroid tests show changes. My body feels like it is in fight, flight, and freeze mode at all times. Mindfulness, meditation, exercise, massage, distracting myself with music, spending time in nature does not change my body state. Thank you to that individual for sharing that. In this article published in Frontiers of Immunology at the end of June, Dr. Ramakrishnan and colleagues reviewed the emerging evidence around the post-COVID condition and identified several potential mechanisms for the problem that we're talking about today. These potential mechanisms, firing either alone or in combination, include, and you can see them here, direct viral invasion, immune inflammatory perturbations, I love that word, hidden viral reservoirs, abnormal metabolic and mitochondrial dysfunction, imbalance in the renin-angiotensin system, and altered microbiome. Now, I want to be really clear with everyone, and I want to emphasize that I am not an expert in any of that. And there are likely people in the audience today that know way more than I do about this. The bottom line is that we don't yet know what causes post-COVID condition. What is known is that people with SARS and MERS experience similar problems, that it's a real thing, even though we don't fully understand it yet. And that's an important thing when I've heard people with post-COVID condition talk about their illness, is that they feel often abandoned by the system and that they can't get the support they need and they're not heard. It's different from the post-ICU syndrome that we know to occur in people who spend a long time in ICU. And actually that happens also in COVID patients. And that there are these possible multiple immunopathological mechanisms that could explain the syndrome. Whatever the mechanism or mechanisms, the effects play out across multiple organ systems as shown here in this diagram, probably because the virus attaches to this ACE2 inhibitor that's throughout our bodies. The post-COVID condition is a complex system disease that profoundly impacts the lives of patients. And as you can see, these are a number of the common presentations, clinical presentations of post-COVID condition. People have ongoing shortness of breath, chest pain, cough, myocardial inflammation, raised troponins, dysrhythmias. Very commonly, people talk about this brain fog, cognitive dysfunction that occurs, fatigue, some delirium, sleep disturbances, depression, anxiety, PTSD-like symptoms, problems with diarrhea, blood vessel inflammations causing cutaneous manifestations at times, pancreatic injury, renal injury, and on and on. These are not all an exclusive list, but these are the common presentations of the post-COVID condition. How common is it? In the literature, anywhere from 10 to 80%. And I think that this is a good reflection of our lack of understanding of the disease and the different ways that people have tried to understand the prevalence of post-COVID condition in patients. Part of the problem is that not everyone who had COVID had a diagnosis confirmed with a PCR test. Many people didn't get tested at all, and yet they are all people who could develop post-COVID condition. Likewise, many people didn't require hospitalization and just stayed at home and suffered, and we don't know about them. And so there's a lot yet to be learned about the post-COVID condition, its prevalence, and what we are going to be seeing. Who gets it? Anyone can suffer. Anyone who's had COVID can suffer from the post-COVID condition. And that's part of the challenge with this. But we're coming to know that women are more likely to suffer with post-COVID condition for reasons that nobody understands completely yet. And just like we saw with the pandemic in general, we see that those with the least resources to manage and cope are disproportionately hit by this condition. And given the size of our Indigenous population in Saskatchewan, I think that this is an opportunity for us to address one of the Truth and Reconciliation calls to action, number 22. and trying to bridge the gap in healthcare provided and not make this worse instead of better. So that's a little personal challenge from me to all of us. One of the things that is not immediately evident when people talk about post-COVID condition is the potential impact on our healthcare system itself. COVID was and is the pandemic we weren't prepared for. It caught healthcare systems off guard time and again, and continues to do so. Post-COVID condition is the upcoming public health crisis that we need to prepare for. To understand the potential impact of post-COVID condition, we need to understand not only what people suffer from, but how severe those symptoms are, how long they last, and what kind of treatment those people will require. Fortunately, the vast majority of patients can be managed at home with supportive care provided by their primary care provider. A smaller number will require the support of interdisciplinary care teams with physiotherapy, occupational therapy, psychiatric care, etc. And a smaller number yet will require specialist care. Fortunately, again, most people will improve with time. The estimations we had in place prior to the fourth wave of the pandemic suggested that we would have about 45,000 people needing self-management, 7,000 requiring interdisciplinary care, and 5,000 needing specialist care by March of 2022. That was prior to the fourth wave. So those numbers will undoubtedly be significantly higher now. In our report, Dr. Lanassi led the section that proposed a model of care for Saskatchewan based on literature and what was being done elsewhere. Dr. Lanassi and his group proposed a model of care that is centered on primary care and that utilized pre-existing structures within the SHA. In order to do this to do this well, primary care physicians will need to learn about post-COVID. They'll need to have educational materials in that regard. And they'll need to stay abreast of new information coming out. And materials to support patients in their self-management will need to be developed and updated as new evidence emerges. Fortunately, this foundational work is underway even in the midst of this fourth wave. Developing a pathway for diagnosis of the post-COVID condition will be the next step. What we presented to the EOC was but a blueprint, if you will. We gave them some idea of how this should happen without operationalizing it. I've been assured that this work of operationalizing that blueprint will begin after Christmas. What that will look like exactly, I don't know. We didn't take things down to the fine details. It's unclear, for example, whether we will in Saskatchewan have COVID-specific clinics, and if so, what level within the system those would exist at. Given the known unknowns, an ongoing learning health system approach will be critical to be able to adapt and change whatever pathway does get implemented. And as a result, we felt that we felt that there's a few research-related recommendations that we really need to consider. One would be to establish a provincial registry of persons who experience long COVID and are entering into this future COVID pathway from whatever point of entry, so we know who they are. Establishing a long COVID research group to guide the ongoing work and develop national and international collaborations would be very value added. Conducting studies to estimate the prevalence of the long COVID condition in Saskatchewan would also be very helpful. Creating a mechanism to engage long COVID survivors in all research related work would also be helpful. Consistent with the learning health approach, building in opportunities for patient and provider involvement in ongoing program evaluation that leads to continuous improvement based on Saskatchewan specific data would be, in our mind, critical. And supporting and encouraging research to engage with the long COVID research group to access data and conduct research related to clinical interventions to manage long COVID, evaluate innovative care models and support needs, etc., would also be helpful. This is a new emerging disease entity and public health crisis if we don't manage it properly. I'm grateful that the SHA is looking to do just that. Thank you.
Okay, thank you so much, Dr. Groot, for a very nice presentation and for sharing the latest research on the topic, as well as some of the recommendations that came out of the interdisciplinary working group. So we now have time for a few questions, and we'll open it up to the audience. Those on the FeedLoop platform can type their questions into the chat feature. For any on Zoom who are not on FeedLoop, you can raise your hand and Shania will unmute you so you can ask your question. Sorry. As we wait for questions to come in, I'll just ask a question that came to my mind, Gary. So one of the recommendations from the report was to develop a registry that would enable a broad range of research in Saskatchewan, and I think that's an excellent idea. However, Saskatchewan currently has databases that capture all lab-confirmed COVID cases. Has there been any thought about doing a study to estimate the prevalence of long COVID in a much more accurate way using our COVID population as a starting point?
So I know that there is a research group in the province that's looking to capture self-declared people through social media in terms of the incidence of long COVID. If we just go with the COVID database, the people that have been diagnosed with COVID, we would miss all the people that have COVID that never got a PCR test and that now have symptoms. And so it depends what our goal is. And if our goal is to only make access and support people that have a PCR diagnosed case of long COVID, we'll miss quite a few people, I think. So we need a broader approach in my mind. And I think most researchers would agree with that. And that's why we were suggesting a database where once we have a pathway, if that happens, and there's multiple entry points into it, if we could just have all of those people identified and create a registry within the SHA that says these people now we know where we fit the diagnosis or the definition, the World Health Organization definition of long COVID, we can track those people. But in the meantime, the sort of work that others are doing already around trying to understand the prevalence within Saskatchewan will be value added and feed into that. And we're a pretty small province. So I mean, I really like the idea of having, a working group or a research group that says, okay, if you're interested in doing work on long COVID in Saskatchewan, be a part of that. It's a very non-exclusive, sort of an open invitation for people to participate.
Yes, absolutely. And hopefully more work will happen. It is quite a challenge to have a prevalence estimate from 10 to 80% of all diagnosed COVID cases with experiencing long COVID symptoms. So we'll watch for more work on that. So there's a question here from Chris Pliszka. He says, maybe less COVID related, but based on your earlier comment in your presentation, do you have any thoughts on if we should encourage more researchers to directly address health system issues or priorities rather than recreational questions? If so, do you have ideas on how this could be done?
So I think there are, thanks, Chris. You just like to ask the hard questions, eh? I have a bias as a relatively new researcher. I came to research late in my career. I think that there are various kinds of research, and they all are legitimate. Basic science research is critical, and we need basic science researchers. And I think there's space within this issue of post-COVID condition where we would need people in basic science to help us understand what exactly is going on. That's important. There's other people that will be interested in doing more health services research and understanding policy and how it plays out, and something like what we're talking about here, where you're going to have a pathway for a new disease entity that we don't know exactly what's going on. The evidence is emerging, so you'll need a different group of researchers who will want to be interested in addressing those research questions. And finally, I think there'll be other kinds of researchers who will do what Brent James, who's my mentor, would call recreational research, sort of asking recreational questions, trying to understand, going with a hypothesis and trying to understand as much as they can about a particular question. I think we need all kinds of researchers, not just one kind.
Okay, well, great. Gary, I see one more question here, so I will, and then I think we're at time, unfortunately. So Tammy asks, is there any indication in the preliminary data that different age ranges are more susceptible to long COVID?
Not particularly, as far as I could see. I mean, there's conflicting reports, but if you look at all the literature put together, I would say no. We don't have a lot of literature yet on children, and we have very little evidence yet. This is one of the questions that is in my mind. Is the Delta variant different in terms of the way it plays out in the post-COVID condition than the early versions of the pandemic where we had the Alpha variant? So those are all still emerging questions that we don't have answers to. But no, it doesn't seem like it's any more so, other than we saw more people, obviously, in the older age group early on that had COVID. And so a lot, because they were represented more early on, they probably are seeing more long COVID from them, rather than it's just more common in that age group.
Okay, well, we'll continue to watch the literature, I'm sure, with interest. So we are at time, and I'd like to thank Dr. Groot again for presenting today. Next on our program is the interactive poster session. So for those who are registered for Showcase and have Feed Loop access, please make sure to visit Poster Hall and say hi to one of a number of our presenters. I think there's almost 100 abstracts and posters there. And then we will reconvene at 10 a.m. for the concurrent sessions, which will feature patient-oriented research and emerging issues. So you'll join these sessions through Feed Loop by selecting the sessions menu, and SHA leaders can also access the Zoom links through the Outlook invite in your calendar, and Andrea just sent an update on that. So if you want to join, you have the Zoom links as well. Thank you, everybody, and we'll see you back here at 10 o'clock after Poster Hall. Thanks.